Hey guys, Steve Moran here with another episode of Foresight TV. I am so pumped up. My background looks a little weird. I'm in a Marriott hotel in Washington, D.C., where I've just finished up amazing NIC conference, had great conversations. We'll have a lot of conversation and content for you in the next few weeks about what we learned here, and probably most people from NIC are traveling home, so they won't see this as it's live. Today's really I've been really looking forward to this. It's sort of an unusual thing. I'm very curious. I wander around the world and I'm always looking for ideas that will make senior living better, particularly for the people who live and work there. And so I came across this story about this weird company called Braden Health, and they go in and they buy up these broken down hospitals that nobody can figure out how to run, and they turn them into these great successful businesses. And so Kyle sort of leads up this effort for Braden Health, and we are going to see what we can learn from him that might apply to senior living. But first, this. Hey guys, Steve Moran here. Kyle, welcome.
Thank you so much for having me, Steve. It's great to be here.
I am really excited about this. So let's start by talking about Braden Health and what your mission is to make the world a better place.
Yeah, absolutely. So we're sort of a grassroots healthcare group that came together a couple years ago in South Florida. There's been about 139 rural hospital closures that have been tracked by the University of North Carolina. And our role is sort of to see where we can make that number go down for sort of in a simple term, really. We're here to see where we can make the most impact. And we've started in Tennessee, reopening failed hospitals and stopping hospitals from failure.
So let's talk a little bit about, actually, I want to ask you another question. This is one bit we talked about for just a minute personally before went on the air, but you look too young to be doing this. How did you end up doing this?
Yeah, so I live in a small town called Ave Maria, Florida. I sort of spent the later part of my youth there and went to school down there. Dr. Braden had also lived down there, and we were just sort of starting up a rural health clinic, essentially a free clinic for the area. There was no hospital within about 50 miles or so. So I started getting involved with him back then when we were working on that, and he was doing consulting for different hospital groups, and then went through school and did a stint at the White House and did some work with the U.S. Coast Guard Auxiliary, and then came back to work with him as my term was ending there. And that's sort of around when our model changed from consulting on certain hospitals and making recommendations to purchasing failing hospitals.
Okay, so let's talk about why these hospitals fail.
Yeah, absolutely.
Yes.
So there's a myriad of reasons for them, but they really essentially boil down to a few things, which is poor management, lack of oversight, and a failure to modernize is really your top three things. And then the biggest thing, which is the fourth thing, is the lack of community support. Over the last 20 years, I'd say about half of America's rural hospitals have seemed to lost the support of their community. And that really shows, of course, states vary on how they track data, but a great way to track it is by how many patients those hospitals are actually admitting. And if you look at rural hospitals, you see those numbers sort of just fall at a pretty dramatic pace. And, that's not really something that you would expect to see, right? The demographics in rural areas, while they are sort of declining at a steady rate, they don't indicate that you would have such a dramatic fall. And really what that boils down to, at least from what we've seen and observed in our realm of work, is the lack of community support.
And is that because they've just lost confidence, or because there aren't docs, or are they not modernizing, or all of that, some different?
Yeah, usually what we see is, a good rule of thumb there is if you work at the hospital, would you want to be treated there, right? Would you want your family to be treated there? Would you want your mom to be treated there? And when we go to a lot of these rural hospitals, what we see is a lot of the equipment is incredibly outdated, and the doctors don't have the support that they need, whether it's through the administration or through the clinical staff having their resources cut, to be able to serve that patient in a manner to where you and I would want to be taken care of, or we trust our family, our spouses, our children to be taken care of. And the community is incredibly intelligent. The people want their hospital to survive, right? You really don't want to be in the back of an ER or in the back of an ambulance for an hour or so trying to get to an ER. You want that local hospital to be there. So what you usually see is it starts to taper at first, right? You sort of have folks that really try and stick on as long as they can, but once it gets to a point where the beds are 30 years old, the X-ray machine is 50 years old, the CT scanner, which we need to determine if someone's having a stroke or maybe a bleed or something of that nature, just doesn't work. I mean, it becomes more harmful in a way than good. So at that point, you just sort of see a correlated decline in patient volumes.
And so these are people who are, because the quality is so poor, they're willing to drive an hour or more to get better medical care. And,
Yeah.
and so these hospitals they typically have an ER, and are they typically staffed by a 24-hour doc?
Yes, they do. So our hospitals are all, 24 hours a day, 7 days a week, emergency departments, fully staffed, fully equipped. And then they usually have the inpatient unit attached, which is your standard medical surgical unit for those of you that are in the industry. And for those of you that are laymen, medical surgical units are essentially what you would think of as your hospital wing, right? Where you stay for a couple of days, where you're treated, where the nurses round on you regularly.
Now, and of course, these are actually, I'll back up a little bit. Towns, how big are the towns that these are typically in?
Yeah, so it depends on, what type of rural hospital. And a critical access hospital, sort of our smallest, and a sort of a special designation by Medicare. You see those towns of about 8,000 to 10,000 people or smaller in the population centers of the counties. For fee-for-service rural hospitals that we have, they're usually between about 20 and 30,000 individuals.
So that's actually a pretty good sized town.
Yes, it is.
Yeah. And typically it's the only hospital in town, or is that always the only hospital in town?
In our case, it's usually been the only hospital in the county, and sometimes the neighboring counties. Rural areas tend to have sort of a population center. And sometimes it's the county seat. Sometimes it's something that's close to the interstate, and that's usually where they're found.
Yeah. I used to be a volunteer ski patrol in Southern California, and the town of Big Bear had the hospital. And in many respects, I think they had a small med surge, but it was mostly a transfer station. And I can remember one weekend we were up there, and we typically there were two mountains in the area, but we typically backboard 6 people a day, and they all would need CT scans. And I remember one time we got up there and the CT machine was broken in the local hospital, which means they had to fly or ambulance everybody down. And it just wasn't ideal for everybody. So how do you find these hospitals?
Yeah, hospitals sort of tend to give out very similar signs when they're in trouble, sort of like a patient when they're sick, right? Illness is usually readily apparent. So most states have some mandatory reported data. Centers for Medicare and Medicare Service put out a ton of data, and we track it. And we have some internal metrics that really identify when hospitals are in trouble. And, usually a member of my team will reach out and say, hey, we're from Braden Health, and, we're wondering what's going on at this hospital. And then, depending on how those conversations go, Dr. Braden and a team of us will usually go and do the inspection of the hospital to see what's the cause of the problem. Is it something we can fix, or have they gotten themselves into too much trouble? And if it's something we can fix, what do we need to do to turn that around? And then we just sort of continue from there. If we're able to acquire it, great. And if not, we usually try and keep watching it that way. If they get into a situation where they feel comfortable and ready to go, we're right there.
And so your model is always to do acquisitions.
Not always. We have come across some that are completely closed. Haywood County Community Hospital is a great example. And that sort of met all of our metrics to come in and reopen it. Well, rebuild it first and then reopen it.
But so talk to me a little bit about, and this is where I think it really has great application for senior living. I don't know how much you know about the industry, but it's sort of obvious that with COVID, it's been a disaster. For in many locations for many months, they just couldn't even move residents in, or if they moved them in, it was just this terrible thing. And the goal was, of course, just to survive, get PPE and keep people safe. And virtually every building in the country, and I don't remember what the number is, but something like half of all the buildings in the country had at least one fatality of a team member or a resident. We're starting to come out of that now, but we're still really struggling. And we, like, everybody else, not only we're having trouble with staffing, and we're having trouble with wage compression and with margin compression because of inflation. So when you go into one of these hospitals, what do you look for in terms of deciding whether it's a yes or no, is the first question. And then the second one is, how do you go about fixing it?
Yeah. Well, you sort of have to first determine what went wrong, right? You sort of have to do a post-mortem on the hospital. And, it may be very well that the doctors don't want anything to do with it. And then we have to go to them and say, hey, if we get this reopened, knowing sort of our reputation, would you be willing to sign back on? And a lot of time that answer is yes, but that's sort of the first thing, right? Will the community's doctors support us? And, when you're trying to make sort of the argument that, hey, we want a community hospital, and you don't have the support of the community doctors, it's very hard to successfully make that argument to the community and say, hey, look, trust us. By the way, none of the doctors want to work with us. So that's sort of the first place you have to start, is with them. And then you, of course, have to assure that you can have some adequate resources, whether that's supply lines, access to things like the internet, so we can actually run those massive images from those CT or X-ray or other diagnostic equipment to where it's being read and back. But then usually we'll have a meeting with the local government to sort of see where they are on things. In many cases, these abandoned rural hospitals sort of fall onto a county commission or a county industrial development board because they've just been left and the county has to dispose of them. So sort of the next thing we'll look at is the building itself for a standing closed hospital, and for a new build, we'll look at the land plot to sort of see if it fits the metrics for modern building codes for a hospital. And then it's sort of a matter of how do you do it, right? It's a matter of which state you're in, if you have to apply for a certificate of need, or if you can just sort of start turning dirt and go from there. But, what's always really fun about old buildings is you do find a lot of really interesting surprises and remnants. Haywood County, we had to delay the opening there for a few months. It is finally seeing patients, but we had to delay the opening there a few months because the sprinkler system that appeared to be functional was actually just some sprinkler heads kind of drilled into various parts of the building.
Even the fire suppression system.
Right, exactly.
No kidding.
So you get a lot of surprises like that, or, you'll find asbestos in things that were marked as not having any asbestos present. And so you have a lot of those sort of usual old building issues that you have to be flexible around. And you also have to be sure to work very closely with the state regulatory agencies, because as you find these surprises, it could get buried in months of red tape, and you sort of have to have you have to build the relationship of trust with state, saying, hey, look, we need to do this the right way, but you've also got a lot of people dying in your county. So how do we work to make sure we mitigate this properly and don't end up in months and months of unnecessary paperwork? So it's a really big combination of doing the work efficiently while also ensuring that you're being transparent about the work you're doing. So that way the community knows that we're making an effort, we're rectifying the problems that they know existed, whether or not the previous operator or previous provider of healthcare wanted to admit they were happening. And then it's being very clear on what services we're going to be able to provide. So that way, when grandma gets sick, when mom gets sick, when I get sick, or anyone gets sick in the family, it's okay. We can go to the local hospital and we know they'll take care of us.
Now, in these local hospitals, you're not doing things like open heart surgery and those kinds of things, right? These are sort of basic medical care, emergency care, with typically a transfer to, if they've got some serious thing, with a transfer to a bigger hospital.
Right. So we call it bread and butter rural medicine. We're not a specialty orthopedic center, and you really wouldn't want that at a rural hospital because you don't have the volumes to support it. So, it comes a simple question of, do you want the guy who did 2 joint replacements this month or the guy that did 200, right? So that's kind of a not necessarily the right fit for what we're doing. But yes, definitely emergency services, inpatient services. But also you have to have a really strong team. And that's really the beating heart of the hospital. We always say that we can keep about 80% of the issues. Some hospitals were able to keep up to 90%. And that's mainly because of the staff that runs them. Knowing what the community needs, ensuring that they're keeping their budget correct, ensuring that they're keeping on track with their goals of making the hospital a safer place, and also just being good stewards to their community is really what makes it run.
So do you have trouble finding staff and keeping staff?
Usually after acquisition or after we reopen one, we generally seem to have the opposite of what a lot of folks are having, which is we usually get sort of slammed with applicants, and we're very grateful for that. And we offer some pretty competitive compensation packages. I think that plays into it, but I think the biggest part of it is the fact that they are able to care for their community. And it's not, our corporates kind of run a little differently, as we like to joke around. It's not a bunch of us telling folks, how to do it. It's more of a mentorship relationship where, we have certain expectations, but we really rely on the team at the local level to run the hospital and sort of guide them where we can. And I think because of that, I honestly don't think we have too many issues when it comes to recruiting staff. It's a much more collegial environment than many healthcare systems. And that's not a knock on the way other people are doing things. I think we've just found a lot more success because it's like you said, COVID was crazy. People are burning out. They're working really hard, really long hours. And sort of the last thing they need is us at corporate to sort of beat them over the head with it. But, that being said, at the same time, we have to make sure that we're following the Medicare manual very, very closely.
Yep.
And also, ensuring that we're a very safe place to be. So it's a balance, but it also relies on this mentorship because we don't want to be in there every day showing them how to run the hospital. We want to empower them to run the hospital and help.
I love this. So how many hospitals do you have?
Yeah, so we have 6 in Tennessee, and we're in the process of building one in South Florida.
So some of these are actually ground up new construction.
Correct.
But they're still in a rural hospital footprint. So this maybe you don't know the answer to this yet. Do you have sort of middle management that sits between corporate and does sort of the day-to-day interface with the individual hospitals? Or is there no middle there?
Well, it's a mixture of both, right? Usually what you do is the first hospital in an area, or in a grouping of rural hospitals, is they will sort of act as the middle level mentors to the newer facilities, right? So when we take on a new facility, they'll go to that facility that we've had for a year or two, or their administrators or management team or clinical team will come out to that hospital. And usually they can pick up a lot of things, but our team is also sort of on standby, and we do travel. Every officer of the company is a working officer, and we do go out to the facilities and train folks. And that's also how we stay sharp. I mean, I can sit here and tell you that I'm an expert on rural health, but if I've never been to the hospital, it's really silly. And, I've seen a lot of folks try and fail to run rural hospitals, and we've talked to them, and it's, well, we've owned this hospital for 20 years, but this was also the first time we've ever been out to this hospital. It's like, well, no wonder why it's in trouble. Your staff is sort of telling you what you need, what they need. And you can also pick up on a lot of issues by going out and talking to the folks on the ground, because they'll tell you, the nurse that runs the floor, the charge nurse, she knows what's going on in her hospital. You may not want to hear it as a member of corporate, but if you want to do your patient the proper service and provide them with the proper care they need, you need to be able to go down there and say, okay, what can we learn from you?
I love this. I think that in a lot of the larger senior living organizations, there are CEOs, COOs, and particularly probably more so CFOs who actually never go inside the buildings. And the converse of that is that I talk to a lot of leaders inside and outside of senior living, because we're all about how do we help people, have better lives who live and work in senior living. So how do leaders do that better? And what you just described is consistent. What I hear everybody who has a great organization is they go into the building and they listen to people and say, what's going on? What do you need to make it better? And so that is really, really terrific.
Yeah. And part of it too is, it's one thing to go out there and talk to the folks, but we also have to have enough understanding to know, why we're doing things a certain way, why the requirements say that you have to do X, Y, and Z. And the reason why we do that is, that way when we're having those conversations, if we need to make a process, we know the rules involved with changing the process, if it's a Medicare requirement, and we can just change it. But if we have to do something a certain way because of a state statute or a federal statute, we can explain that to the staff on the ground that, hey, we're not trying to make your life difficult by filling out this form. Here's the actual regulation that says we have to do that in this state, which is why we don't do it in other states. But, if you want to change it, feel free to contact your legislature.
That's right. So I want to take just a quick break here and run a short message from one of our sponsors for Foresight TV. So here's my question that I love to ask guests from outside. Somehow pixie dust drops onto you in the middle of the night, and you're going to add a new portfolio mix to what you're already doing at Braden Health, and you're going to take on senior living. And you wake up tomorrow morning, or Monday morning, we'll call it Monday morning on Friday, and you discover that you now have a portfolio of 25 senior living communities that are operating at 72% occupancy, there's 70% staff turnover, and you need to get up to 90% occupancy in order to make the building successful. What are you going to do? Where are you going to start?
I think the very first place that I would look would be, what was the last time the staff at all of these facilities, the lower level staff, had any sort of wage raises? The second thing I would look at would be our payer contracts to see what we're being paid for this, right? We're nearly at capacity, but we have a lot of turnover. That's a huge problem. So either we're not being paid appropriately so we can get enough equipment and that's new and able to take care of folks to where the staff feels comfortable working, or maybe we're just not paying our staff right. I think those first two things in mind and having the knowledge as to where we stand on those, I would then go out to the facilities and talk to each one of the facility CEOs and see with the ones that had the most staffing turnover and see where their greatest challenges are. And maybe it's a leadership thing at the local level, but I sort of bet dollars to donuts that, if we're able to get those contracts under control, that we might be able to make a pretty big change.
Cool. So I just had somebody coming in looking. I'll be done in about 5 minutes. So I really love this, and again, it's this consistent theme of you go out and you ask questions. And so one of the things that I didn't clarify for you that makes it a little bit different is most of these do not get any reimbursement at all. So it's going to be essentially all private pay, and so. Of course, that means much more competitive, but I really like that a lot. So how many of these hospitals do you think do you have sort of a roadmap of how many of these you'll do?
Yeah.
How long? Go ahead.
Yeah, so the UNC Cecil Shepp Center tracks rural hospital closures. We're at about 139 that have failed so far, with a huge concentration in the Southeast, mainly in Tennessee and Texas. And then depending on whose data source you look at, whether it's, the Office of Government Research or whether it's Congress, they estimate anywhere between 300 and 500 hospitals in rural areas will close over the next 10 years. So we really have our work cut out for us, but I think we're going to try and go to as many of the ones that are in trouble and explore as many of the ones that are abandoned as we can and see just how many we can reopen. And at the same time, we're going to keep working in DC and at state levels to see where we can enact change. So that way, not only us can do it and groups like us, but many others can sort of join in where it got complicated and just help as many people as we can.
So are they pretty much in every state? Probably Alaska doesn't have a lot.
Yeah, they've had a couple closures, but yeah, they seem to have a few less closures than and it just comes down to numbers, right? Population and density. But yeah, out west they seem to be running them a lot better than they are in the Southeast.
Well, do you have any thoughts as to why that is?
It comes into the way that they're managed. Dr. Braden and his team did spend a lot of time out west in the early years. And, there's a couple other groups that run rural hospitals very well that are just central out there. The Southeast has not had those groups have much of a presence until we started really doing work out there.
So it sounds like, I guess what I'm sort of hearing from you is that it doesn't sound like the problem is so much not getting adequate reimbursement. It's just using that reimbursement well.
Yeah, it comes down to running a business, right? If you're sort of asleep at the wheel, the business is not going to do very well. And, it's always a unique challenge to be in a rural environment and have sort of a limited reimbursement structure. And sure, that is an aggregating factor for many different reasons, but it's not the only factor, and it's certainly not the main factor for hospital closures. Otherwise, we wouldn't be able to report to the state of Tennessee year after year profitability, and groups like us wouldn't be able to do that across the United States. So it doesn't just come down to the issue of, well, reimbursement is poor, so the hospital doesn't work. Really what it comes down to is, this is the resources you have. Here's where you can negotiate, and this is the resources you're left with. How do you make it work?
So, two quick, we're just about out of time. Two quick questions. The first is, do you struggle once the doctors are on board and you sort of done your rehab? Do you struggle at all to get the community to support, or are they generally just sort of relieved and glad to come back in?
It certainly takes a little bit of time, and we have to be very transparent with the local news. Just ensuring that they can see everything about the hospital, because rural areas, especially recently, have just been hurt by some bad actors sort of claiming that they're going to come in and reopen their rural hospital that have just sort of done some horrible things. So there's a healthy amount of fear, I think, that develops in parts of the community when they hear it. But once we're able to get the word out there and they're able to see the equipment, usually we'll do some open houses and things and ensure the county commissioners get to walk through and ask questions of the doctors and the nurses. And, we've done the same thing with state governors too, and legislatures. And once we're able to do that, we're able to gain a lot of support, because it's not really us just saying, hey, look, our hospital is great. It's, hey, we opened a hospital. We think it's great. Why don't you come look at it? And we're open to your feedback on it. And we've also been able to learn a few lessons that way too. Whether it's ensuring that we can help the state work with, transfers of severely mentally ill folks that just really require some additional resources. To, hey, when this hospital closed in 2014, you'll see a bin of hand-painted tiles that are in the corner that the first grade class did when the hospital opened. Is there any way you can save them? And, we've done that at certain sites. So, community support is going to be there if you do what you say you're going to do, and if you empower your leaders to actually run the facility. And if you don't do that, you're just not going to win it.
Do you ever run into communities where the quality of the physicians is just not adequate?
We have seen some of that. Usually what you'll have, though, is a lot of very kind-hearted physicians that care. It's very rare. It has happened, but it's very rare to find a physician that, isn't up to the standard that you need them to be. And there's many things you can do there. You don't necessarily just say, well, that was nice, which I think a lot of groups do these days. We offer a lot of remedial training too, to where if someone's just, or maybe they haven't had it, and they need it. And we're happy to do that. But, in the rare case that we're not able to find some local doctors, we have doctors that are willing to go from other hospitals to help.
Okay, cool. So just one more sort of broad question as a leadership question. Are you reading anything, either books or or websites or podcasts or anything that you like on leadership that you'd recommend?
Yeah, I think it's sort of constant, right? There's a lot of different methods of leadership, a lot of different models. And for us, we'll read something and then we'll take it back to our core group and say, here's what I've learned, in this leadership manual or that. And here's the challenges that I discovered in it that maybe won't fit well. So we'll talk about principles and things, but really at the end of the day, we just sort of try and use whatever common sense we can.
And I think that's probably the best advice at all, is the common sense is a wonderful thing. Well, Kyle, thank you very much. This has been terrific. Why don't you hang on for just a second after we go off the air? And with that, we will see you all next week.